Good afternoon, good morning, and evening to my friends and colleagues in different parts of the world. I'm going to talk about pylon fractures. Just for the sake of convenience, I've divided this talk into four parts: a brief introduction. I'll just touch upon classification systems that have been described, and then my primary focus will be on management of these fractures, what is evidenced in literature, and what has been our experience through some representative cases. And I hope to leave you with a small message at the end of this talk. Fractures of distal tibial metaphysis with involvement of articular surface at the ankle joint are considered the pylon fracture. These are usually high energy, complex, and serious injuries resulting from compression and sometimes from torsional forces as the talus gets driven into the tibial platform. The term tibial pylon was introduced by a French radiologist because the distal shape of the distal tibia resembled the pharmacist's pestle or pylon. So these are serious injuries. They are often associated with significant soft tissue trauma, which may be an open fracture or closed fracture, but soft tissue trauma is a component of the injury anyway, mostly. They form 5 to 10% of tibial fracture. It can be isolated fracture or a part of polytrauma. Sometimes there is dislocation of the ankle as well, along with the pylon fracture. Now, what is more intriguing is that there is no unanimity on treatment of these fractures till date. And there is significant complication rate. Post-traumatic osteoarthritis is almost given, especially in serious grade 2 and grade 3 injuries. The mechanism of injury determines the fracture pattern, whether the injury was with foot in plantarflexion or plantigrade or dorsiflexion, and then the mechanism of injury will determine the fracture pattern. Here are some examples of pylon fracture. This is a relatively simple fracture, slightly more comminuted. This is associated with dislocation and significant comminution and a fracture of the fibula as well. Now, the common complication of these fractures are wound breakdown, pin problems, depending if it was treated with external fixation, infection, especially in plating cases, malunion, delayed union, non-union, complication can be there in any fracture and more so in pylon fractures. And then post-traumatic osteoarthritis, again, this being an intra-articular fracture and weight-bearing joint, is quite likely in sphere type of fractures. Classification system. A variety of classification systems have been described, but the most commonly used in clinical practice is the Rudy and Algovers, which is a fairly simple classification system. Then there is AO and OTA classification system, and lately a CT-based classification system has been described by Atkins and his colleagues. Here is the Rudy and Algovers classification. There are three types. Type 1 with minimal joint displacement without no significant joint replacement is type 1, and type 2 is significant displacement of articular surface but minimal comminution, and type 3 is significant comminution along with major joint involvement. Mostly these are the compression injuries, as we said, and sometimes they can be torsional. AOATA classification, I'm just mentioning them for completeness. I'm not going to go into the detail. These are the fracture number 43. And then like in any other fracture described by AO, type A, type B, type C. And type A have 1, 2, 3, type B has 1, 2, 3, and type C has 1, 2, 3. They almost correspond with ABC correspond with 1, 2, 3 of Rudy and Thomas classification. So here are the further details about this classification system. There is poor to moderate inter-observer and intra-observer reliability for both AO and Rudy and Algover classification systems. Now, this is the latest classification system. Atkins and his colleagues described 10 types of fracture patterns, and that was the classification based on CT scan findings. They described anatomy of fracture fragments. There are 6 types of fracture fragments described by them, and then there are 4 types of fracture categories. There are 4 different families of fracture categories they have described. Again, I'm not going to go into the details, just will quickly run through these slides. The fracture fragments can be medial, anterior, posterior, anterolateral, and posterolateral. Medial, anterior, posterior, anterolateral, posterolateral, and then there is a die punch fragment type. All the fragments may not be present in every fracture. The families are coronal, sagittal, and then grossly comminuted, which are undifferentiated and maybe marginal fractures. Coronal fracture again have got further five types depending on the fracture pattern, and similarly, sagittal family of fractures have also three types depending on the fracture pattern. Apart from the fracture classification, the soft tissue injury, the open fractures, commonly practiced, classification is the Gustlow classification. We all know about this. There's no need for me to go into the details. Now, sometimes there may not be an open wound, especially in these fractures, and still there is significant soft tissue injury. Then we can classify it as per the Oster and Cherney classification, which are grade 0, 1, 2, 3, 4. 1, 2, 3. These are the four types of soft tissue damage without an open wound. And then if there is an open wound, they have also described four types, which are the first three are almost similar to the originally described in Gustlow type of fractures. And the fourth type, open injury, is where there is almost incomplete or complete amputation. So all in all, various classification systems for pilon fracture describe the different fracture patterns and severity of injury. Distinct anatomical fragments have also been described based on CT findings. Their knowledge is essential for proper injury documentation, assessment, recording of data, and planning of treatment, and they help in prognosticating the patient as well. As far as diagnosis is concerned, plain radiographs are usually enough to make the diagnosis. Full-length film, including knee joint, help in assessment of alignment, and CT scan are, however, helpful in assessing the extent of injury and planning the exact treatment plan for reconstruction of the ankle joint. Coming to the management. The goals of treatment, like in any other intra-articular fracture, the goal of treatment is first restoration of articular congruity. Then align the articular fragment in the main diaphysis, axial alignment, and then provide stability to the joint to help early mobilization so that the joint function can be restored. The soft tissue are managed depending on the merit of their injuries. A variety of conservative and surgical methods have been described, including skeletal traction and plaster, minimal internal fixation, percutaneous screws, open reduction, and internal fixation with plate has been popular method for quite some time. And then external fixation, variety of external fixation, spanning, ankle spanning or joint sparing fixators. And then lately, two-stage procedures have been described, which have become quite popular and they are in vogue these days. Rarely, primary arthrodesis may also be an option where there is a grossly destroyed joint which is beyond reconstruction. The choice of treatment depends largely on patient's condition, the facilities available, and surgeon's expertise and preference. It is necessary to assess the soft tissue damage, extent of joint involvement, and the degree of comminution to plan the most suitable treatment strategy. Associated comorbidities and sometimes other injuries which are a part of polytrauma can influence the choice and timing of treatment. Type 1 injuries, Alguber and Rudy, they can be treated conservatively or minimal internal fixation. However, type 2 and type 3 usually need surgical treatment in the form of open reduction internal fixation or maybe X-fix in a different variety of modes. We can use X-fix. Open reduction internal fixation with plates has been the preferred method of treatment for a long time. However, this method has been observed to be associated with high rate of soft tissue problems and infection, especially in situations where soft tissues were compromised and in open fractures. In last couple of decades, advent of minimally invasive plate osteosynthesis and development of modern low profile locking plates have helped reduce these complications, but only to an extent. So what is in literature, written in literature about these fractures? As I've already said, there is no unanimity, but still on the basis of literature, we can have some conclusions that we can make. You know, many studies are published comparing different types of fixation and operative methods. Most of these studies are retrospective studies, so no definitive conclusion can be made. Scientific and evidence-based conclusion can be made, and most studies do not compare similar type of fractures with the different treatment methods, and that is another problem in literature about these fractures. As we know, like in any other fracture, the results here also would depend on severity of initial injury and accuracy of reduction of the articular surface, and that is what would determine the long-term results. Now, if we look at literature, this study compared ORIF with XFix with plus limited inter ORIF. Though at 2 years there was not much difference in the final results, but with the ORIF group they observed increased frequency and severity of complications. Now there is another study with a prospective study with a protocol of ORIF. Here they found severe wound complication and higher non-union and malunion rates, especially when the soft tissue was also involved. This study compared three different methods: ORIF versus MIPO versus two-stage, that is initial treatment in XFix and then MIPO. They found best results with the two-stage procedures. Another study again, ORIF with two-stage, not much difference here in this study because they were in Elizorov. Now this is a meta-analysis of 9 studies where they reviewed compared the results between ORIF internal fixation with another method was external fixator with limited internal fixation. Here again, they did not find much difference and complication rates were almost similar. Joint spanning or joint sparing fixation. There are a couple of studies, but not much to choose from. None of them could recommend which one is better. Both gave almost similar type of results. Good one study and one meta-analysis almost similar. This study was retrospective. Now, staged protocol in last couple of decades that has become quite popular, and there is this study with 56 patients. Initial, they fixed the fibula in all cases, then spanning external fixation followed by delayed ORIF. They reported minimal wound complications. Similarly, another study of 51 patients where they compared primary ORIF or XFix, three groups: primary ORIF, XFix, and XFix with delayed MIPO. Again, the delayed MIPO, the stage procedure, gave the minimal complication rate, the lowest complication rate. Now, this is one random control trial published by Wang and his colleagues between two-stage procedure versus XFix and limited internal fixation. And they did not find much difference because none of these two groups was treated by plating. So all in all, there is very little conclusive evidence of one type of fixator or treatment being better than the other. Comparative studies between treatment by variety of plates and fixator have failed to prove superiority of one method over the other. In general, skin problems and infection rates have been higher with the use of plates, and pin problems, malunion, delayed union have been more frequent with the external fixators. However, having said that, external fixators have got a definite role in the management of pilon fracture. First of all, they can be the method of choice for first aid. It can be a definitive treatment also if we can restore the articular surface with minimal internal fixation by percutaneous screws, and then we can use external fixation as a definitive treatment with a final phase in a plaster cast. These days, however, there is a move towards initial XFix followed by MIPO as a two-stage procedure. Now, what has been our experience? I'm going to show with some representative cases. This was a pilon fracture, relatively simple, but it was an open fracture. So we did minimal internal fixation and put a fixator across the ankle, and this fracture went on to heal very well and with good function. This is another fracture with, this is a dislocated ankle and a bad pilon fracture. This was a very elderly patient with uncontrolled diabetes, and skin condition was also not good. This was the X-ray after we reduced the dislocation, and this was the CT scan. We can see, and this is what we did for this patient. We did minimal internal fixation and then put an X-fix across the ankle to stabilize this. This was all right. The wounds healed fairly well, but fracture went into delayed union. So we had to do bone grafting after about 3 months or so, and it went on to heal, but we could not prevent a slight malunion. But despite this, there was good function in this patient, and the patient was happy. There were no complications. This is another patient, again a severe open fracture, relatively simple fracture pattern. So we used minimal internal fixation to restore articular surface and then stabilize the metaphysio-diaphyseal fracture with K-wires. Then this was supported by an X-fix. And this X-fix had a articulated X-fix which could help us do intermittent ankle mobilization. This also went on to good union without any significant problems, and the soft tissues also healed. Now this is a patient I'm going to show. This is the last patient where fracture dislocation, the pilon fracture dislocation of the ankle was a part of major polytrauma. Here the circumstances did not allow us to use either X-fix or plating. So I'm going to share with you how we could treat this patient and how we could use a simple method for treating this. This was the ankle. This is the CT scan. This was the CT scan after the close reduction of the dislocation was tried. So this was an unstable one. So they had put a transcalcaneal wire after reducing to stabilize it. Now this is the patient who fell from 30 feet high, though he was a young man, but he had variety of head injury. He had head injury, he was unconscious for a time. There was fracture of head of radius, fracture of ribs with hemopneumothorax, 5 ribs, fracture of 2 lumbar vertebra, and a very bad pelvic injury with sacroiliac disruption on one side, pubic symphysis disruption on, also, and then sacrococcygeal, very bad sacrococcygeal fracture dislocation and badly bruised perineum. He also had left grade 2 open fracture on the left side, open leg fracture, and then he had perennial soft tissue. Now, what was worse was that this patient presented to us 7 days after the injury in a very bad shape. He was semi-conscious, high fever with pyothorax with subcutaneous emphysema. Hemoglobin was only 6 gram, and all blood parameters were deranged. Badly swollen, bruised perineal region with bleeding abrasions. Though the left tibia was nailed with an open raw area which needed coverage, and there was a transcalcaneal pin across the right ankle. As I said earlier, there was a transcalcaneal pin. This was already nailed, and this eventually needed bone grafting one later on, and the skin coverage was done. Now here, since it was in a very bad shape and it was polytrauma, we had to prioritize our different treatment plans. So first of all was to stabilize the general condition, give him transfuse IV antibiotics, and stabilize his chest injury. And then the perennial injury was very bad, so we had to look at that and restore it, and that gradually improved. And after that, we wanted to cover the wound on the left leg. Once all this was stabilized, it took us about 10 days. And then we thought, since he had two spine vertebral body fracture, it was important to make the patient turn around to prevent bed sores. So spine fracture got priority over the ankle fracture. And then it was only after this, it took us about a couple of weeks before we could reach the pilon fracture dislocation on the right side. I had to first, this is the sacrum coccygeal fracture dislocation. You can see this disruption here on the right side, sacroiliac joint. This was the spine fracture, one view only. So I had to first stabilize this once the patient was, general condition was stable and his hemoglobin could be brought up. After this, I came to this thing, and here we could not put plate because there were very high fear of infection, and we could not put X-fix because that would obstruct the turning of the patient to different sides. So we had to do only minimal internal fixation, restore the articular surface. Now here, though it doesn't look that bad, but there were many chips. You can see the talus top and the talus back. This was all multiple small chips of the bone flowing all around in the ankle joint, which had to be removed. So the talar superior surface was also very raw and rough at many places, and the distal articular surface of the tibia, of course, had multiple fracture fragments. So though the X-ray looked good, but we knew that these are the raw surfaces. And till for first 2 weeks we gave him a slab and allowed supervised ankle motion and helped him regain a significant degree of ankle motion. But then once the sutures were out, we wanted to distract the fracture fragments. And for that we needed a fixator, but we could not put fixator because we wanted the patient to take turn and then gradually mobilize also. So we put a pin and plaster. We put a pin through the calcaneum and pin through the proximal tibia and then distracted the ankle joint. And then this was the principle of external fixator used in a plaster. So after that, the patient eventually everything healed. He did very well. Of course, he developed. This is the 6 years down the line. He developed osteoarthritis, but it is now about 15 years, and he has got good function. Though occasional pain in the ankle, he's still doing well. So we are just keeping our fingers crossed about the ankle joint. And this is the function at the ankle. So, friends, my message is that Pilon fracture classification systems describe fracture patterns and severity of injury. They're usually associated with an element of soft tissue injury. Primary ORIF has shown to have high complication rates. Primary X-fix with minimal internal fixation, or a two-stage procedure with the initial X-fix followed by a delayed BIPO. And these two methods have given almost similar results as reported in literature, and any one of them, depending on the experience of the surgeon and the conditions, can be picked for treating these fractures. These are some of the references, and thank you very much.